Today, we are going to talk about a situation that is becoming increasingly common. It involves a young woman named Anne. Anne is 25 years old. She works as a graphic designer. She should be excited about life, but instead she feels completely overwhelmed. Anne lives with a roommate in a shared apartment. This is typical for many young adults starting careers. For Anne, home is becoming a source of conflict. Friends and family have noticed significant changes. They see her struggling. Their concern pushed Anne to seek professional help. She is caught in a difficult cycle of depression. Cannabis use. Anne's story starts with a common coping choice. She started using cannabis about 3 years ago. At first, it was a way to unwind after a long day. It helped with job pressure. Over time, occasional use grew into something more significant. Now she uses cannabis every single day. She smokes several joints a day, far more than she intended. It's no longer just about stress relief. It has become central to her daily routine, a routine she feels she cannot escape. This excessive use is causing major problems. Consequences are piling up. Job performance is suffering. She has missed work and received warnings. Financial strain is considerable. Much of her income goes to buying cannabis. She has little left for other necessities. Her relationship with her roommate is strained. The smell of smoke and her disengagement spark frequent arguments. These conflicts increase her isolation and stress. Anne feels trapped. She watches her life unravel and feels powerless to stop it. This is a critical turning point. In this series, we'll follow Anne's journey. We'll take a structured approach to understand her situation. Our goal, move from overwhelm to a clear, actionable care plan. We'll break the case into chapters, starting with a thorough assessment. We'll explore underlying issues, diagnose the conditions, then build a comprehensive treatment strategy. This process gives Anne tools and support. It's about empowering her to regain control of her mental health and life. A story about finding a path forward, even when it seems impossible. Anne is not just dealing with a substance use problem. She is also battling significant depressive symptoms. She describes a persistent feeling of sadness that clouds her every day. Feelings of worthlessness, feelings of hopelessness. These are classic signs of depression. The joy she once found in her hobbies has vanished. Hiking now feels like a chore. Socializing with friends now feels like a chore. This loss of interest, known as anhedonia, is a core feature of depression. It has left her feeling empty and disconnected from the world and from herself. Her emotional landscape is bleak and unforgiving. Her physical health is also reflecting her internal struggle. Anne reports feeling tired all the time, a deep fatigue that sleep does not seem to fix. Her appetite has changed, leading to noticeable weight gain. Her sleep patterns are completely disrupted. She struggles with insomnia at night, lying awake for hours with racing thoughts. In the day, she is plagued by excessive sleepiness, making it hard to function. These physical symptoms are not separate from her emotional state. They are intertwined, creating a vicious cycle where poor sleep and low energy worsen her depression. The cognitive effects are severely impacting her professional life. As a graphic designer, her job requires creativity, concentration, decisiveness. Anne finds she has none of these. Her mind feels foggy. She struggles to focus on her tasks. Making decisions, even small ones, feels insurmountable. This has led to missed deadlines and a decline in the quality of her work. She has received warnings from her employer, increasing her anxiety and sense of failure. Anne is filled with self-doubt. She lacks the motivation to try to catch up, feeling bound to fail. Anne's case highlights a complex interplay between major depressive disorder and cannabis use disorder. She acknowledges her cannabis use is excessive. She does not currently see the connection between smoking and her depressive symptoms. In her mind, cannabis is coping, not the cause. This lack of insight is common in dual diagnosis cases. Our primary goal is to carefully assess both conditions. We need to understand how they influence each other. By doing so, we can create a targeted care plan for both depression and substance use, offering a real chance for recovery. Table of Contents. Part 2. Act 1. Assessment. 5 sections. 1. Framing the assessment. SPAR. 2. Unpacking the symptoms. 3. The mental state examination. 4. Screening tools and physical health. 5. Forming a differential diagnosis. To begin our assessment of Anne's situation, we need a structured way to organize the information. In clinical settings, we often use a framework called SPAR, Situation Background Assessment Recommendation. It helps us communicate clearly and effectively. For Anne, the situation is critical. She is a 25-year-old female, presenting with severe depressive symptoms, heavy, uncontrolled cannabis use habit. The immediate problem is her deteriorating mental health, significant functional impairment at her job, significant functional impairment in her personal life. Concern from friends and family triggered help seeking. This framework ensures we capture the most urgent issues first. Next, we consider the background. 3-year history of daily cannabis use. It started as a way to manage stress, now escalated to several joints per day. Family history of depression, family history of anxiety. This suggests a potential genetic vulnerability. Previous depressive episodes, never formally diagnosed or treated. This lack of prior treatment is important. We are starting from scratch. She has not had negative experiences with therapy or medication that might make her hesitant. The assessment part of SPAR involves our initial clinical impression. Mood disorder, substance use disorder. Symptoms align with major depressive disorder. Cannabis use meets criteria for cannabis use disorder. Significant distress. Daily functioning is severely compromised. Disheveled. Lethargic. Affect is blunted. Thought process slow and tangential. Assess the risk of self-harm. She denies active suicidal thoughts. Feelings of hopelessness are a major red flag. Finally, the recommendation sets our immediate course of action. Conduct a comprehensive psychiatric and substance use evaluation. Use standardized screening tools to quantify symptom severity. Perform a physical exam. Order basic laboratory tests. Rule out underlying medical conditions that could be causing or worsening symptoms. The initial plan should focus on ensuring her safety. Begin patient education about her conditions. Start exploring treatment options collaboratively. This structured approach ensures nothing is missed as we move from overwhelm to a clear plan. Let's break down Anne's symptoms in more detail. The emotional symptoms are profound. She reports persistent feelings of sadness, worthlessness, hopelessness. These are not just fleeting bad moods, they are a constant heavy blanket over her life. This is the core of a major depressive episode. She also experiences anhedonia, the inability to feel pleasure. Hobbies she used to love, hiking, seeing friends. These activities now feel like burdensome tasks. This loss of interest isolates her further. It robs her of activities that could lift her spirits. These feelings create a feedback loop. Sadness leads to withdrawal, and withdrawal deepens the sadness. The physical symptoms Anne is experiencing are just as debilitating. She reports significant fatigue and excessive daytime sleepiness. This is more than just feeling tired. It's a profound lack of energy, making even simple tasks feel monumental. At night, she struggles with insomnia, lying awake for hours, her mind racing with negative thoughts. This sleep disruption is a classic symptom of depression and can also be affected by chronic cannabis use. Furthermore, she has noticed changes in her appetite that have led to weight gain. This physical change can negatively impact her body image and self-esteem, adding another layer to her feelings of worthlessness. Cognitively, Anne is struggling immensely. As a graphic designer, her job relies on her ability to concentrate, be creative, and make decisions. Right now, she feels a pervasive brain fog. She has poor concentration and finds it incredibly difficult to stay on task. Indecisiveness plagues her, making her second-guess every choice, like work projects, and even what to eat for lunch. This cognitive slowing directly affects her job performance. She has missed deadlines, and her work quality has declined, leading to warnings from her employer. These professional struggles fuel her self-doubt and create a cycle of anxiety and failure. She feels incompetent and unmotivated, which only worsens her depression. Finally, we must look at the behavioral and social symptoms. Anne has become socially withdrawn. She avoids friends and family, the very people who are concerned about her. Her personal responsibilities are being neglected, evident in her disheveled appearance and poor hygiene. Her home life is strained. Conflicts with her roommate over her smoking habits and their impact on the shared living space are frequent. These interpersonal conflicts increase her stress and sense of isolation. The combination of social withdrawal, neglect of responsibilities, and diminished work productivity paints a clear picture of how deeply her conditions are affecting every single aspect of her life. Section 3. The Mental State Examination, a window into Anne's world. A mental state examination, or MSE, is a crucial part of our assessment. It is like a physical exam for your mind. It gives us a snapshot of a person's psychological functioning at a specific point in time. When we first meet Anne, her appearance and behavior give us immediate clues. She presents as casual but disheveled, with signs of poor hygiene. This suggests a lack of energy and motivation for self-care, a common symptom of depression. She appears lethargic, moving slowly and seeming disengaged from the conversation. We also note that she often fidgets with her personal items, which can be a sign of underlying anxiety or restlessness, despite her overall low energy. Next, we observe her mood and affect. Anne's self-reported mood is one of persistent sadness and hopelessness. Her affect, however, is what we observe externally. We would describe Anne's affect as blunted. This means her emotional expression is significantly reduced. She does not smile, her face is often blank, her voice is monotone. There are occasional moments where she expresses frustration, especially when talking about her job or her roommate, but these expressions are brief. The disconnect between a potentially turbulent inner world and a flat outer expression is a key indicator of depression. We then assess her speech and thought process. Anne's speech is slow, reflecting her overall lethargy. It takes her a noticeable effort to formulate her thoughts and express them. Her thought process is tangential. For example, when asked about her work, she might start talking about a specific project, then drift to her feelings of failure, and then to a conflict with her roommate. This difficulty staying on track is a sign of her cognitive struggles and poor concentration. It makes gathering a clear history more challenging, but is diagnostically very important. Finally, we look at her thought content and cognition. Anne's thoughts are dominated by persistent negative self-criticism. She is very hard on herself, constantly thinking about her perceived failures. She reports feeling hopeless about the future, a dangerous cognitive distortion. Crucially, we must assess for suicidal ideation. Anne denies any active plan to harm herself, which is reassuring. However, her profound hopelessness is a significant risk factor that must be monitored closely. In terms of her basic cognition, she is oriented to person, place, and time. Her judgment, however, is poor, particularly regarding the impact of her cannabis use on her mental health. Section 4. Screening Tools and Physical Health. Gathering Objective Data. To supplement our clinical interview and mental state exam, we use standardized screening tools. These are questionnaires that help us measure the severity of Anne's symptoms objectively. For her depression, the Patient Health Questionnaire 9, PHQ 9. 9 items. She rates symptom frequency over the last 2 weeks. Her score would likely be high, severe range, confirms major depression, provides a baseline to track progress. For substance use, a cannabis-specific tool. The Cannabis Use Disorder Identification Test revised, CUDIT-R. Questions about frequency of use, questions about dependent symptoms, questions about related problems. She smokes several joints daily. She's facing negative consequences. QDIT-R score would likely be high, severe QD. Optionally, use a broader screener like Cage Aid for drugs and alcohol. These tools shift the talk from, "Do you have a problem?" to, "How is this substance impacting your life?" Consider Anne's physical health. Don't assume symptoms are purely psychiatric. Many medical conditions can mimic or worsen depression. A thorough physical exam is necessary. Order basic labs, complete blood count, CBC, check for anemia causing fatigue, check thyroid function with TSH, depressive symptoms, weight gain, fatigue, liver function tests, given substance use. Ruling out medical causes ensures an accurate diagnosis. Finally, a formal risk assessment, beyond just asking about suicide. Evaluate severity of hopelessness. Ask about passive death wishes, e.g., wishing to sleep and not wake. Assess her support system. Who can she call if hopelessness becomes unbearable? Assess access to means of self-harm. Does she have a safety plan? Because of impaired judgment and hopelessness, take this seriously. Ensuring immediate safety is the top priority before other treatment. Section 5. Forming a differential diagnosis. Considering the possibilities. After gathering all this information, we begin forming a differential diagnosis. This means creating a list of possible conditions that could explain Anne's symptoms. Visual flowchart. Depressive symptoms branching to MDD, substance-induced, medical causes. Our leading diagnosis, major depressive disorder, MDD, and cannabis use disorder, CUD. Symptom, persistent low mood, anhedonia, sleep changes, appetite changes, fatigue, feelings of worthlessness. These symptoms are a textbook presentation of MDD. Simultaneously, her pattern of compulsive use, functional impairment, and inability to cut down. These clearly meet criteria for CUD. These two conditions are likely feeding into each other in a destructive cycle. However, we must consider other possibilities. One important differential is substance or medication-induced depressive disorder. Here, depressive symptoms would be a direct physiological result of cannabis use. Chronic heavy cannabis use can, in some people, produce a state identical to major depression. The key question is timing. Did the depression start before the heavy cannabis use? Or did it only appear after her use escalated? Anne reports previous depressive episodes before her cannabis use became so heavy. That points more toward two independent disorders. Still, cannabis is very likely making her depression significantly worse now. Another possibility is persistent depressive disorder, PDD, also called dysthymia. PDD is a chronic lower-grade depression lasting at least 2 years. Anne's history of prior episodes might suggest an underlying chronic condition. It's possible she has PDD with a superimposed major depressive episode, double depression. Differentiating PDD from recurrent MDD requires a detailed multi-year timeline. That distinction affects long-term treatment. PDD often needs sustained therapy. Finally, always keep other medical causes on the list until they're ruled out. Conditions like hypothyroidism or anemia. These can present with fatigue and low mood. Neurological conditions should be considered if symptoms are atypical. Vitamin deficiencies, low vitamin D, or B12 deficiency. These can also contribute to depressive symptoms. The physical exam and lab work are essential to systematically rule these out. Only by carefully considering and eliminating alternatives can we reach the most accurate diagnostic formulation for Anne. That diagnostic formulation is the foundation for an effective treatment plan. To understand what Anne is going through, we first need to look at the brain's inner workings during depression. Think of your brain as a complex communication network. Messages are sent using chemical messengers called neurotransmitters. 3 key players in mood regulation are serotonin, norepinephrine, dopamine. Serotonin helps regulate mood, sleep, appetite. Norepinephrine influences alertness, energy. Dopamine is crucial for pleasure, motivation, reward. In depression, the balance of these neurotransmitters is disrupted. The signals are not being sent or received correctly, leading to the persistent low mood, lack of energy, loss of pleasure that Anne is experiencing. It's not a character flaw, it's a biological imbalance. The brain's stress response system is also deeply involved. This system, known as the HPA axis, hypothalamic pituitary adrenal axis, is our body's central alarm. When we face a threat, it releases stress hormones like cortisol. In healthy individuals, this system turns off once the threat is gone. However, in people with chronic stress or a predisposition to depression, the HPA axis can become overactive. It stays on, continuously flooding the brain with cortisol. High levels of cortisol can damage brain cells, particularly in areas like the hippocampus prefrontal cortex. These areas are vital for memory, learning, emotional regulation. This contributes to the cognitive fog, negative thought patterns, and reports. Another important concept is neuroplasticity. This is the brain's incredible ability to change and adapt by forming new connections between brain cells. It's how we learn and create memories. In a healthy brain, this process is active and robust. However, chronic stress and depression can significantly reduce neuroplasticity. The brain becomes less adaptable, more rigid. It gets stuck in negative patterns of thinking and feeling. The good news is that this process can be reversed. Treatments for depression, including therapy and medication, work in part by promoting neuroplasticity, helping the brain to form new, healthier pathways and essentially rewire itself out of the depressive state. Finally, we have the brain's reward pathways. These circuits, rich in dopamine, are designed to make us feel good when we do things necessary for survival, like eating, socializing. They create motivation and drive. In depression, this reward system becomes blunted. Activities that once brought joy no longer trigger the same release of dopamine. This is why Anne has lost interest in hiking, seeing her friends. The reward she used to get from these activities is gone. This anhedonia is a core symptom of depression and creates a powerful cycle. When nothing feels good, there is no motivation to do anything. Isolation, worsening mood. Now, let's turn our attention to cannabis and how it interacts with the brain. The cannabis plant contains hundreds of chemical compounds. The two most well-known are THC delta-9 tetrahydrocannabinol and CBD cannabidiol. THC is the primary psychoactive component. It causes the high. It mimics a natural neurotransmitter in our bodies. Our brains have a built-in system called the endocannabinoid system, or ECS. The ECS helps regulate mood. It regulates appetite. It regulates sleep. It regulates pain. THC hijacks the ECS by binding to its receptors. It binds especially to CB1 receptors in the brain. THC binding to a CB1 receptor on a neuron, disrupting normal communication. That produces powerful but artificial effects. The ECS is a master regulator that maintains balance, or homeostasis. When cannabis is used, THC floods the system and overwhelms it. In the short term, cannabis can produce euphoria. It can also produce relaxation. It can temporarily increase dopamine release, which feels pleasurable. That's why Anne initially found it helpful for managing stress. CBD works differently. CBD does not produce a high and can counteract some of THC's effects. CBD interacts more indirectly with the ECS. CBD has been studied for anti-anxiety effects. It has also been studied for antipsychotic properties. The THC to CBD ratio in what Anne uses greatly changes the effect. The problem comes with chronic, heavy use. Constant THC exposure makes the brain try to protect itself. The brain reduces the number of its CB1 receptors. This process is called downregulation. The ECS becomes less sensitive as a result. The body's ability to regulate mood weakens. Its ability to regulate stress weakens. Its ability to regulate sleep weakens. The person then needs more cannabis just to feel normal. This is the basis of tolerance and dependence. Anne's daily several joint use has likely caused significant downregulation. making her brain reliant on external THC. Chronic use also affects other neurotransmitter systems. Cannabis can initially boost dopamine. Over time, it can blunt the entire dopamine system. That leads to low motivation and reduced ability to feel pleasure, a motivational syndrome. That looks very similar to the anhedonia of depression. Chronic use can also disrupt serotonin. Chronic use can disrupt norepinephrine. Both disruptions further destabilize mood. So the substance Anne uses to cope is reshaping her brain chemistry, making her more vulnerable to sadness and stress. The relationship between cannabis use and depression is complex and bidirectional. It's the classic chicken and egg scenario. For some individuals, heavy cannabis use can trigger the onset of depression, especially in those with a pre-existing genetic vulnerability like Anne's family history. The chronic disruption of the brain's reward system. The chronic disruption of the brain's stress system can pave the way for a major depressive episode. The substance that was meant to provide relief ends up becoming a primary cause of the distress. This is the substance-induced pathway, depressive symptoms as a direct consequence of drug effects on brain chemistry over time. More commonly, however, people with depression turn to cannabis as a form of self-medication. This is likely how Anne's journey started. Feeling overwhelmed, sad, anxious, the initial calming and euphoric effects of THC can feel like a welcome escape. It can temporarily quiet negative thoughts and numb emotional pain. The problem is that this is a very short-term solution with dangerous long-term consequences. The relief is fleeting, and as the effects wear off, the underlying depression often returns, sometimes even stronger than before. This creates a powerful cycle, using cannabis to escape depression while cannabis worsens depression over time. One of the most insidious interactions is masking symptoms. When Anne is high, she might not feel as sad or hopeless. That can prevent recognition of how severe her condition is. It also blocks development of healthier coping mechanisms. Instead of learning to manage emotions or solve stressors, she reaches for a joint. That crutch may feel helpful short-term, but it prevents real progress. It keeps her stuck, covering root causes with a chemical blanket. Chronic cannabis use also sabotages behaviors that fight depression. Behavioral activation asks patients to re-engage with positive activities, social connections, but cannabis use often brings a motivational syndrome, social withdrawal lethargy. It makes it harder to go for a hike, call a friend, or even get out of bed. In short, cannabis isn't just another problem. It's an active barrier to recovery, undermining therapeutic efforts before they can begin. To move from assessment to a formal diagnosis, we use a standardized guide, the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5. For major depressive disorder, the criteria require at least 5 specific symptoms present during the same 2-week period. At least one must be depressed mood, loss of interest or pleasure, anhedonia. Anne clearly meets this threshold. Persistent sadness, diminished interest in hobbies, significant fatigue, sleep disturbances, changes in appetite with weight gain, poor concentration, feelings of worthlessness. These symptoms cause clinically significant distress and impair functioning, fulfilling MDD criteria. Next, evaluate for cannabis use disorder. DSM-5 lists 11 criteria for substance use disorders. Diagnosis requires at least 2 within a 12-month period. Anne's case suggests severe CUD. She uses cannabis in larger amounts and for longer than intended. She has a persistent desire, but is unsuccessful in cutting down. A great deal of her time and money is spent obtaining and using cannabis. She is experiencing functional impairment, recurrent job absences and warnings. She continues to use despite social problems, conflict with her roommate. All these points strongly indicate a CUD, likely severe, meeting 6 or more criteria. The crucial diagnostic question: how do these two conditions relate? Is it MDD with co-occurring CUD or cannabis-induced depressive disorder? The key distinction lies in the timeline and persistence of symptoms. A substance-induced disorder requires symptoms developing during or soon after substance use, and the substance is judged etiologically related to the disturbance. While Anne's cannabis use exacerbates her depression, her report of previous depressive episodes before heavy use began suggests a primary mood disorder. Therefore, major depressive disorder, recurrent, with co-occurring severe cannabis use disorder. This diagnosis has profound implications for treatment. We cannot just treat the depression and hope cannabis use stops, nor only treat cannabis use and expect depression to resolve. We must develop a treatment plan targeting both conditions simultaneously. The dual diagnosis approach acknowledges the complex interplay between the disorders. It validates Anne's overwhelming sadness and her loss of control over substance use, setting the stage for a comprehensive, empathetic care plan that addresses the full scope of her challenges. The pathophysiology of Anne's conditions has a direct and devastating impact on her cognitive functioning, which is the engine of her professional life. As a graphic designer, she relies on what we call executive functions. These are a set of high-level mental skills managed by the brain's prefrontal cortex. Planning, organizing, problem-solving, sustaining attention, regulating emotions. Both depression and chronic cannabis use are known to impair these exact functions. The disruption of neurotransmitters like dopamine and norepinephrine in depression leads to poor concentration and indecisiveness. Her brain simply lacks the chemical fuel needed for sharp, focused thought. Cannabis use compounds this problem significantly. THC's effect on the brain prefrontal cortex, hippocampus, short-term memory, attention learning. When Anne is high, her ability to encode new information and maintain a coherent train of thought is severely compromised. But the effects are not limited to periods of intoxication. Chronic heavy use can lead to lasting cognitive deficits that persist even during periods of abstinence. The brain fog she describes is a real phenomenon, a result of the cumulative impact of THC on her brain's processing speed and efficiency, making creative and analytical work feel impossible. This cognitive fallout creates a vicious cycle in the workplace. Anne's inability to focus leads to missed deadlines, a decline in the quality of her work. This results in negative feedback and warnings from her employer. This professional failure becomes fodder for her depressive thoughts, reinforcing feelings of worthlessness, incompetence. She might think, "I can't do anything right. I'm a failure." This negative self-talk deepens her depression, which in turn further impairs her cognitive abilities. Her cannabis use becomes a misguided attempt to escape this cycle, but it only serves to further degrade the cognitive tools she needs to succeed. Beyond her job, this cognitive impairment affects her daily functioning in countless ways. Managing finances, planning meals, following a conversation. Her poor judgment, especially regarding her cannabis use, is a direct result of this impaired executive function. She is unable to accurately assess the long-term consequences of her actions versus the short-term relief they provide. This is not a moral failing, it is a symptom of her conditions. Understanding this cognitive impact is crucial for developing a realistic care plan. Provide concrete, simplified strategies and external support to help her manage her responsibilities while her brain begins to heal. Our first and most critical priority in Anne's treatment plan is to establish safety and stability. Given her profound feelings of hopelessness, a thorough safety plan is not just a formality, it is an essential first step. This involves a collaborative discussion to identify her personal warning signs of a deepening crisis. Warning signs, coping strategies. People to call. We would work with her to create a list of coping strategies she can use when these feelings intensify. Mindfulness exercises, listening to a specific playlist. Most importantly, the plan must include a list of trusted contacts, friends, family members, a crisis hotline that she agrees to call if she feels she cannot keep herself safe. This plan needs to be written down and easily accessible, providing a clear, concrete roadmap for her to follow during her most vulnerable moments. Once a safety plan is in place, the next immediate goal is to begin stabilizing her daily life. Anne feels completely overwhelmed, so we must break down the process into small, manageable steps. This starts with psychoeducation. It is crucial that Anne understands her diagnoses of major depressive disorder, cannabis use disorder, not as character flaws, but as treatable medical conditions. We would explain in simple terms how her brain chemistry has been affected and how the two conditions are locked in a vicious cycle. This knowledge can be incredibly empowering. It helps to externalize the problem, reducing self-blame and shifting her perspective from "I am broken" to "I am dealing with an illness." This initial educational phase also involves introducing the concept of harm reduction regarding her cannabis use. Demanding immediate and total abstinence is often unrealistic and can cause the patient to disengage from treatment altogether. A harm reduction approach meets Anne where she is. We might start by discussing the goal of reducing her consumption, perhaps by delaying her first use of the day by 1 hour, reducing the number of joints she smokes by 1 per day. This approach respects her autonomy and builds a therapeutic alliance based on trust rather than judgment. It is a pragmatic first step toward regaining control, making the seemingly impossible goal of quitting feel more attainable over time. Finally, we must address the immediate chaos in her environment. This includes helping her create a simple daily structure. We might work with her to set just 3 small, achievable goals for the next day. For example, taking a shower, eating a proper breakfast, going for a 10-minute walk outside. This technique, known as behavioral activation, is designed to counteract the lethargy and withdrawal of depression. It builds momentum and a sense of accomplishment, no matter how small. These initial steps are not about solving all her problems at once. They are about stopping the downward spiral and creating a stable foundation upon which the rest of her recovery can be built. Section 2. Building a foundation. Non-pharmacological interventions. With safety and initial stability addressed, we can build the core of Anne's treatment plan using non-pharmacological or therapeutic interventions. A cornerstone of this approach is motivational interviewing, or MI. MI is a conversational technique to help Anne explore and resolve ambivalence about cannabis use. Rather than telling her cannabis is bad, we use MI to ask open-ended questions that reveal discrepancies with long-term goals. For example, on one hand, cannabis helps you relax, but on the other hand, how does it fit with your goal of performing well at work? This builds internal motivation for change, more powerful than external pressure. Alongside MI, we introduce cognitive behavioral therapy, CBT, thoughts, CBT, feelings, CBT, behaviors. We start by identifying automatic negative thoughts such as, "I'm a failure," and "nothing will ever get better." Next, we challenge these distortions by examining evidence for and against them. We use CBT to address cannabis use by identifying triggers, people, triggers, places, triggers, feelings. Then develop alternative, healthier coping strategies for high-risk situations. This gives practical tools to manage mood and substance use. Behavioral activation is central here. We schedule activities that provide pleasure or mastery, even when motivation is low. Re-engage with hobbies like hiking. Start with a very short, easy trail, or schedule a brief coffee meeting with a supportive friend. Principle: action before motivation. These behaviors bring positive reinforcement and can rebuild blunted reward pathways. That helps combat anhedonia and lethargy. We track activities so she can see how what she does affects how she feels. Finally, we address disrupted sleep, a major factor in fatigue and poor mood. Implement a strict sleep hygiene protocol. Set a consistent bedtime and wake-up time, even on weekends. Avoid screens for at least an hour before bed. Phone. Avoid screens. TV. Avoid screens. Computer. Blue light can interfere with melatonin production. Make the bedroom a sanctuary for sleep only. Cool. Make the bedroom a sanctuary. Dark. Make the bedroom a sanctuary. Quiet. Explain cannabis may feel sedating but disrupts sleep architecture, causing non-restorative sleep. Improving sleep boosts energy. Improving sleep boosts mood. Improving sleep boosts cognitive function. Section 3. The role of pharmacology antidepressant therapy. While therapeutic interventions are crucial, the severity of Anne's major depressive disorder warrants consideration of antidepressant medication. Low energy, poor concentration, anhedonia, a selective serotonin. Reuptake inhibitor would be a good first-line choice. SSRIs, sertraline, SSRIs, escitalopram. They increase serotonin levels by blocking reuptake. Animation, SSRI blocking reuptake, more serotonin in the synapse. This can help. Low mood. This can help. Anxiety. This can help. Obsessive negative thoughts. We would need to have a very clear discussion with Anne about what to expect from medication. It's essential to manage expectations. These are not happy pills. They do not work overnight. It typically takes 4 to 6 weeks to feel the full therapeutic effects. Some initial improvements in sleep may be noticed sooner. Some initial improvements in energy may be noticed sooner. The goal is to lift her mood so she has the energy and mental clarity to fully engage in therapy. Medication provides the biological leg up to do the hard work of recovery. Behavioral activation. Medication helps with challenging negative thoughts. Another option is an antidepressant that affects norepinephrine or dopamine. Bupropion, a norepinephrine dopamine reuptake inhibitor. Bupropion is more activating and can help with fatigue. Bupropion can help with motivation. Bupropion can help with poor concentration. It also has fewer sexual side effects, which can improve adherence. Some evidence suggests bupropion may help reduce cannabis cravings. The decision of which medication to start is collaborative, shared decision-making. We'll present options and discuss potential benefits and side effect profiles. SSRIs can sometimes cause initial nausea. SSRIs can sometimes cause initial fatigue. Bupropion can sometimes increase anxiety. Bupropion can sometimes cause insomnia. By involving her in the choice, we empower Anne and increase the likelihood she'll adhere to the plan. We would start with a low dose and titrate it up slowly over several weeks, monitoring for therapeutic effects and adverse reactions. Section 4. Medication in context. Side effects, interactions, and cautions. When prescribing medication for Anne, it's imperative to discuss potential side effects and interactions, especially given her ongoing cannabis use. For SSRIs, common initial side effects can include nausea, headache, dizziness. These often subside within the first couple of weeks. Longer-term side effects can include weight gain, sexual dysfunction. These effects can be distressing and impact adherence. Be transparent about these possibilities from the outset. For bupropion, common side effects include dry mouth, insomnia, sometimes increased anxiety or agitation. Bupropion lowers the seizure threshold, so take a careful history to rule out seizure risk factors. Interactions between antidepressants and cannabis are critical to address. No absolute contraindication exists, but combining them carries risk. Cannabis can potentially counteract antidepressant effects. An SSRI working to stabilize mood can be undermined by THC's intoxicating and demotivating effects. Both cannabis and many antidepressants can cause drowsiness and cognitive slowing. Combining them can amplify those effects, leading to significant impairment such as driving, operating machinery. Frame these risks to Anne as safety and treatment effectiveness, not as prohibition. A major caution: benzodiazepines. Examples: alprazolam, lorazepam. They may be prescribed short-term for anxiety or for insomnia, but for someone with a substance use disorder, they carry high risk of dependence, tolerance, misuse. They can lead to a second substance use disorder. Thus, they should be strictly avoided. For acute anxiety or severe insomnia, choose safer, non-addictive options. Examples: hydroxyzine for anxiety, trazodone for sleep. Both can be effective without the same dependence risks. Include a clear strategy for specialist referral if needed. If Anne doesn't respond to first-line antidepressants, or if her cannabis use escalates despite interventions, refer to an addiction psychiatrist. An addiction psychiatrist can offer specialized psychopharmacological strategies, such as second-line medications or combination therapies. They can also provide higher levels of care, connecting her with intensive outpatient programs or other structured substance abuse treatment settings. Knowing when to escalate care is a key part of a responsible, effective treatment plan. Section 5. Monitoring and moving forward, a collaborative path. A treatment plan is not a static document. It is a dynamic, evolving roadmap that requires continuous monitoring and adjustment. To track Anne's progress, we will use a combination of subjective reports, objective measures. We will schedule regular follow-up appointments, initially on a weekly basis, to discuss how she is feeling and what challenges she has encountered. During these sessions, we will re-administer the PHQ-9 questionnaire. This provides a numerical score of her depressive symptoms, allowing us to objectively track her response to treatment. A significant reduction in her PHQ-9 score over time is a clear indicator that the plan is working. Monitoring her substance use is equally important. We will use a non-judgmental approach, asking her to keep a simple daily log of her cannabis consumption. This is not for scolding, but for data collection. It helps both Anne and us to see patterns, identify high-risk times, and celebrate successes, such as days where she met her reduction goals. Reviewing this log together can open up conversations about what strategies are working and which are not. This collaborative review reinforces the therapeutic alliance and keeps her actively engaged in her own recovery process, fostering a sense of agency over her life. The monitoring plan also involves regularly assessing for side effects from her medication. At each visit, we will ask specific questions about her sleep appetite, energy levels, and any new or bothersome physical symptoms. If she is experiencing difficult side effects, we have several options. We can wait a bit longer to see if they resolve, adjust the dosage, change the time she takes the medication, or switch to a different antidepressant. This proactive management of side effects is crucial for ensuring she can tolerate the medication and is willing to continue taking it long enough for it to become effective. Ultimately, the entire process of monitoring and adjusting the plan must be collaborative. We will set clear, measurable goals together. Short-term goal: reduce cannabis use by 25%. Short-term goal: complete one scheduled pleasant activity 3 times this week. A longer-term goal might be achieve a PHQ-9 score below 10 and maintain 2 consecutive weeks of abstinence from cannabis. By setting these goals together, we ensure they are meaningful and realistic for Anne. This approach transforms the treatment from something that is being done to her into a journey that she is actively co-piloting, which is the most sustainable path from overwhelm to lasting recovery. Section 1. A consolidated vision, the integrated care plan. In concluding Anne's case, we consolidate all the elements into a single, cohesive plan of care. This is not merely a list of treatments. It's an integrated strategy, recognizing the interconnection between her major depressive disorder and her cannabis use disorder. The foundation is the dual diagnosis approach. Treating one and ignoring the other is a recipe for failure. The immediate focus remains on her safety. A robust, accessible safety plan she helped create. This plan is her lifeline, a concrete tool to navigate moments of intense hopelessness, ensuring she has a clear path to support when she needs it most. That proactive stance on safety provides the secure base from which all other therapeutic work can proceed. The consolidated plan weaves together pharmacological and non-pharmacological interventions. The chosen antidepressant, likely bupropion, chosen for activating properties and potential to reduce cannabis cravings. It serves as a biological scaffold, not a cure, but a facilitator to lift the fog enough for engagement. The psychological work centers on cognitive behavioral therapy. Cognitive behavioral therapy gives practical skills to challenge negative thought patterns. And on motivational interviewing. Motivational interviewing gently guides her toward strengthening her internal resolve to change cannabis use. Lifestyle modifications are elevated to essential components of recovery. A structured sleep hygiene protocol is implemented to restore her sleep-wake cycle. Behavioral activation becomes scheduled therapeutic activity. Simple goals like a daily 10-minute walk. Psychoeducation is ongoing, reinforcing that she's battling a medical illness, not a personal failing. This comprehensive approach treats Anne as a whole person, addressing the biological, the psychological, and the social dimensions of her distress. The ultimate vision is to move Anne from passive suffering to active participation in her own wellness. Each component is designed to empower her. The safety plan gives her control in a crisis. The medication provides the energy to act. The therapy offers the skills to think and behave differently. The lifestyle changes help her rebuild her life from the ground up. This is not a quick fix. It is a long-term strategy for sustainable change. It's a collaborative roadmap she helped to draw, clinically sound, personally meaningful, and achievable. Section 2. Navigating the path forward, discharge and follow-up. The transition from the intensive planning phase to long-term management is defined by a clear discharge and follow-up plan. This plan acts as the scaffolding supporting Anne as she implements these changes in daily life. The initial cadence of contact will be frequent, with weekly appointments scheduled for the first 1 to 2 months. These sessions are critical for monitoring her response to medication, reviewing her progress with harm reduction goals for cannabis use, and providing ongoing therapeutic support. We will use the PHQ-9 at each of these early appointments to get an objective measure of her depressive symptoms, allowing us to make timely adjustments to the treatment plan if she is not responding as expected or is experiencing difficult side effects. A crucial part of the follow-up plan involves communication and engagement with her wider support system, with her explicit consent. We would discuss the benefits of involving her family or a trusted friend in her recovery journey. With her permission, a family session could be arranged to educate her loved ones about her conditions, explain the treatment plan, and guide them on how they can provide the most effective support. Similarly, if her workplace issues persist, we could, with her consent, help her navigate communication with her employer about potential workplace adjustments, such as temporary flexibility with deadlines or hours, framing it within the context of a medical condition for which she is receiving treatment. Relapse prevention is a cornerstone of the long-term strategy and will be a central theme of the follow-up process. As Anne begins to feel better, we will work with her to identify her personal relapse signatures for both depression and cannabis use. What are the early warning signs that things are heading in the wrong direction? Together, we will create a relapse prevention plan that outlines specific, proactive steps she can take when these signs appear. This might include re-engaging with her CBT skills, scheduling an extra therapy session, or reaching out to a support person. This prepares her for the inevitable challenges and setbacks, reframing them not as failures, but as opportunities to learn and strengthen her coping skills. The plan also specifies clear criteria for the escalation of care. We must be prepared for the possibility that outpatient treatment may not be sufficient. These criteria would include a significant increase in self-harm risk, a severe and rapid decline in her medical or mental state, or a complete loss of daily functioning, such as being unable to leave her apartment or care for her basic needs. If these criteria are met, the plan outlines the next steps, which could involve referral to an intensive outpatient program, a partial hospitalization program, or, in a crisis, an emergency psychiatric evaluation. This ensures that a safety net is always in place, ready to catch her if her condition worsens significantly. Section 3. Empowerment and Hope, the Cornerstones of Recovery. Ultimately, the journey from overwhelm to a coherent care plan is a journey toward empowerment and hope. Anne arrived feeling powerless, trapped in a seemingly unbreakable cycle of depression and substance use. Assessment diagnosis, collaborative treatment planning, designed to systematically dismantle this feeling of powerlessness. By explaining the pathophysiology of her conditions, we replace self-blame with understanding. By using shared decision-making in choosing a medication, we position her as an active partner in her care, restoring her sense of agency and reminding her she has a voice and a choice. The emphasis on measurable goals is a powerful engine for building hope. When you are lost in the fog of severe depression, the idea of getting better can feel abstract and impossible. Reduce your PHQ-9 score by 5 points in the next month. Achieve 3 cannabis-free days this week. Each small victory, each ticked box on her behavioral activation chart, is tangible proof of progress. This incremental success builds momentum. Hope fuels action. Action inspires more hope. It transforms a bleak outlook into a realistic, step-by-step belief in a better future. The case underscores the critical importance of empathy and a non-judgmental stance. Anne's hesitation about her cannabis use is not defiance, but a symptom and a coping attempt. A rigid, authoritarian approach would likely have pushed her away. Harm reduction, motivational interviewing. These build the trust necessary for her to explore the true impact of substance on her life. Therapeutic alliance, empathy, and respect allows honest conversations and courageous changes. In conclusion, even in co-occurring depression and substance use disorder, a path forward exists. Not simple or easy, but clear. Accurate diagnosis, evidence-based interventions, collaborative and empathetic approach. Moving from chaos to a structured, measurable, and compassionate plan provides a tangible framework for hope. We empower Anne to reclaim her narrative, a journey of resilience, recovery, and rediscovery of a life worth living.